Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Omitting axillary dissection in breast cancer with sentinel-node metastases. Background. Trials evaluating the omission of completion axillary lymph node dissection in patients with clinically node-negative breast cancer and sentinel lymph node metastases have been compromised by limited statistical power, uncertain nodal radiotherapy target volumes, and a scarcity of data on relevant clinical subgroups. Methods. We conducted a non-inferiority trial in which patients with clinically node-negative primary T1 to T3 breast cancer, tumor size, T1, less than or equal to 20 mm, T2, 21 to 50 mm, and T3, greater than 50 mm in the largest dimension, with 1 or 2 sentinel node macrometastases, metastasis size, greater than 2 mm in the largest dimension, were randomly assigned in a 1-to-1 ratio to completion axillary lymph node dissection or its omission, sentinel node biopsy only. Adjuvant treatment and radiation therapy were used in accordance with national guidelines. The primary endpoint was overall survival. We report here the per-protocol and modified intention to treat analyses of the pre-specified secondary endpoint of recurrence-free survival. To show non-inferiority of sentinel node biopsy only, the upper boundary of the confidence interval for the hazard ratio for recurrence or death had to be below 1.44. Results. Between January 2015 and December 2021, a total of 2,766 patients were enrolled across 5 countries. The per-protocol population included 2,540 patients, of whom 1,335 were assigned to undergo sentinel node biopsy only and 1,205 to undergo completion axillary lymph node dissection group. Radiation therapy including nodal target volumes was administered to 1,192 of 1,326 patients, 89.9%, in the sentinel node biopsy only group and to 1,058 of 1,197, 88.4%, in the dissection group. The median follow-up was 46.8 months, range 1.5 to 94.5. Overall, 191 patients had recurrence or died. The estimated 5-year recurrence-free survival was 89.7%, 95% confidence interval, c. 87.5 to 91.9, in the sentinel node biopsy only group and 88.7%, 95% c. 86.3 to 91.1, in the dissection group, with a country-adjusted hazard ratio for recurrence or death of 0.89, 95% c. 0.66 to 1.19, which was significantly, p less than 0.001, below the pre-specified non-inferiority margin. Conclusions. The omission of completion axillary lymph node dissection was non-inferior to the more extensive surgery in patients with clinically node-negative breast cancer who had sentinel node macrometastases, most of whom received nodal radiation therapy. Trial of Lixisenatide in early Parkinson's disease. Background. Lixisenatide, a glucagon-like peptide-1 receptor agonist used for the treatment of diabetes, has shown neuroprotective properties in a mouse model of Parkinson's disease. Methods. In this Phase 2, double-blind, randomized, placebo-controlled trial, we assessed the effect of Lixisenatide on the progression of motor disability in persons with Parkinson's disease. Participants in whom Parkinson's disease was diagnosed less than 3 years earlier, who were receiving a stable dose of medications to treat symptoms, and who did not have motor complications were randomly assigned in a 1-to-1 ratio to daily subcutaneous Lixisenatide or placebo for 12 months, followed by a 2-month washout period. The primary endpoint was the change from baseline in scores on the Movement Disorder Society Unified Parkinson's Disease Rating Scale, MDS-UPDRS Part 3, range 0 to 132, with higher scores indicating greater motor disability, which was assessed in patients in the on-medication state at 12 months. Secondary endpoints included other MDS-UPTR subscores at 6, 12, and 14 months and doses of levodopa equivalent. Results: a total of 156 persons were enrolled, with 78 assigned to each group. MDS-UPTR's Part 3 scores at baseline were approximately 15 in both groups. At 12 months, scores on the MDS-UPTR's Part 3 had changed by -0.04 points, indicating improvement, in the Lixisenatide group, and 3.04 points, indicating worsening disability, in the placebo group, difference, 3.08, 95% confidence interval, 0.86 to 5.30, p equals 0.007. At 14 months, after a 2-month washout period, the mean MDS-UPTR's motor scores in the off-medication state were 17.7, 95% C, 15.7 to 19.7, with Lixisenatide at 20.6, 95% C, 18.5 to 22.8, with placebo. Other results relative to the secondary endpoints did not differ substantially between the groups. Nausea occurred in 46% of participants receiving Lixisenatide, and vomiting occurred in 13%. Conclusions: in participants with early Parkinson's disease, Lixisenatide therapy resulted in less progression of motor disability than placebo at 12 months in a Phase 2 trial, but was associated with gastrointestinal side effects. Longer and larger trials are needed to determine the effects and safety of Lixisenatide in persons with Parkinson's disease. Nirmatrelvir for vaccinated or unvaccinated adult outpatients with COVID-19. Background: Nirmatrelvir in combination with ritonavir is an antiviral treatment for mild to moderate coronavirus disease 2019, COVID-19. The efficacy of this treatment in patients who are at standard risk for severe COVID-19 or who are fully vaccinated and have at least one risk factor for severe COVID-19 has not been established. Methods: in this Phase 2 to 3 trial, we randomly assigned adults who had confirmed COVID-19 with symptom onset within the past 5 days in a 1-to-1 ratio to receive Nirmatrelvir, ritonavir, or placebo every 12 hours for 5 days. Patients who were fully vaccinated against COVID-19 and who had at least one risk factor for severe disease, as well as patients without such risk factors who had never been vaccinated against COVID-19 or had not been vaccinated within the previous year, were eligible for participation. Participants logged the presence and severity of pre-specified COVID-19 signs and symptoms daily from day 1 through day 28. The primary endpoint was the time to sustained alleviation of all targeted COVID-19 signs and symptoms. COVID-19 related hospitalization and death from any cause were also assessed through day 28. Results: among the 1,296 participants who underwent randomization and were included in the full analysis population, 1,288 received at least one dose of Nirmatrelvir, ritonavir, 654 participants, or placebo, 634 participants, and had at least one post-baseline visit. The median time to sustained alleviation of all targeted signs and symptoms of COVID-19 was 12 days in the Nirmatrelvir, ritonavir group and 13 days in the placebo group, p equals 0.60. 5 participants, 0.8%, in the Nirmatrelvir, ritonavir group and 1.6%, in the placebo group were hospitalized for COVID-19 or died from any cause, difference, -0.8 percentage points, 95% confidence interval, -2.0 to 0.4. The percentages of participants with adverse events were similar in the two groups, 25.8% with Nirmatrelvir, ritonavir and 24.1% with placebo. In the Nirmatrelvir, ritonavir group, the most commonly reported treatment-related adverse events were dysgeusia, in 5.8% of the participants, and diarrhea, in 2.1%. Conclusions: the time to sustained alleviation of all signs and symptoms of COVID-19 did not differ significantly between participants who received Nirmatrelvir, ritonavir and those who received placebo. Pragmatic trial of hospitalization rate in chronic kidney disease. Background: despite the availability of effective therapies for patients with chronic kidney disease, type 2 diabetes, and hypertension, the kidney dysfunction triad, The results of large-scale trials examining the implementation of guideline-directed therapy to reduce the risk of death and complications in this population are lacking. Methods. In this open-label, cluster randomized trial, we assigned 11,182 patients with a kidney dysfunction triad who were being treated at 141 primary care clinics either to receive an intervention that used a personalized algorithm, based on the patient's electronic health record, EHR, to identify patients and practice facilitators to assist providers in delivering guideline-based interventions or to receive usual care. The primary outcome was hospitalization for any cause at 1 year. Secondary outcomes included emergency department visits, readmissions, cardiovascular events, dialysis, and death. Results. We assigned 71 practices, enrolling 5,690 patients, to the intervention group and 70 practices, enrolling 5,492 patients, to the usual care group. The hospitalization rate at 1 year was 20.7%, 95% confidence interval, C, 19.7 to 21.8, in the intervention group and 21.1%, 95% C, 20.1 to 22.2, in the usual care group. Between group difference, 0.4 percentage points, p equals 0.58. The risks of emergency department visits, readmissions, cardiovascular events, dialysis, or death from any cause were similar in the two groups. The risk of adverse events was also similar in the trial groups, except for acute kidney injury, which was observed in more patients in the intervention group, 12.7% versus 11.3%. Conclusions. In this pragmatic trial involving patients with the triad of chronic kidney disease, type 2 diabetes, and hypertension, the use of an EHR-based algorithm and practice facilitators embedded in primary care clinics did not translate into reduced hospitalization at 1 year. Next, we will be discussing articles from Journal of American Medical Association. Prostate-Specific Antigen Screening in 15-Year Prostate Cancer Mortality, a Secondary Analysis of the CAP Randomized Clinical Trial. Importance: a cluster randomized trial of PSA testing for prostate cancer, CAP, reported no effect of prostate-specific antigen, PSA, screening on prostate cancer mortality at a median 10-year follow-up, primary outcome, but the long-term effects of PSA screening on prostate cancer mortality remain unclear. Objective: to evaluate the effect of a single invitation for PSA screening on prostate cancer-specific mortality and median 15-year follow-up compared with no invitation for screening. Intervention: men received a single invitation for a PSA screening test with subsequent diagnostic tests if the PSA level was 3.0 nanograms per milliliter or higher. The control group received standard practice, no invitation. Main outcomes and measures: the primary outcome was reported previously. Of 8 pre-specified secondary outcomes, results of 4 were reported previously. The 4 remaining pre-specified secondary outcomes at 15-year follow-up were prostate cancer-specific mortality, all-cause mortality, and prostate cancer stage and Gleason grade at diagnosis. Results of 415,357 eligible men, mean SD, age, 59.0, 5.6 years, 98% were included in these analyses. Overall, 12,013 and 12,958 men with a prostate cancer diagnosis were in the intervention and control groups, respectively. 15-year cumulative risk, 7.08%, 95% C, 6.95% to 7.21%, and 6.94%, 95% C, 6.82% to 7.06%, respectively. At a median 15-year follow-up, 1,199 men in the intervention group, 0.69%, 95% C, 0.65% to 0.73%, and 1,451 men in the control group, 0.78%, 95% C, 0.73% to 0.82%, died of prostate cancer, rate ratio, RR, 0.92, 95% C, 0.85 to 0.99, p equals 0.03. Compared with the control, the PSA screening intervention increased detection of low-grade, Gleason score, Gs, less than or equal to 6, 2.2% versus 1.6%, p less than 0.001, and localized, T1/T2, 3.6% versus 3.1%, P less than 0.001, disease but not intermediate, Gs of 7, high grade, Gs greater than or equal to 8, locally advanced, T3, or distally advanced, T4/N1/M1 tumors. There were 45,084 all-cause deaths in the intervention group, 23.2%, 95% C, 23.0% to 23.4%, and 5,336 deaths in the control group, 23.3%, 95% C, 23.1% to 23.5%, RR, 0.97, 95% C, 0.94 to 1.01, P equals 0.11. 8 of the prostate cancer deaths in the intervention group, 0.7%, and 7 deaths in the control group, 0.5%, were related to a diagnostic biopsy or prostate cancer treatment. Conclusions and relevance in this secondary analysis of a randomized clinical trial, a single invitation for PSA screening compared with standard practice without routine screening reduced prostate cancer deaths at a median follow-up of 15 years. However, the absolute reduction in deaths was small. Single ascending and multiple dose trial of Zerlasiran, a short interfering RNA targeting lipoprotein A, randomized clinical trial. Importance: lipoprotein A is a causal risk factor for atherosclerotic cardiovascular disease, ASCADE, and calcific aortic stenosis, with no pharmacological treatments approved by regulatory authorities. Objectives: to assess the safety and tolerability of Zerlasiran, a short interfering RNA targeting hepatic synthesis of apolipoprotein A, and effects on serum concentrations of lipoprotein A. Design, setting, and participants: single and multiple dose study in healthy participants and patients with stable ASCADE, respectively, with lipoprotein A serum concentrations greater than 150 mol/L, conducted at 7 research sites in the US, the Netherlands, UK, and Australia between November 18, 2020, and February 8, 2023, with last follow-up on August 23, 2023. Interventions: participants were randomized to receive 1. A single subcutaneous dose of placebo, N equals 8, Zerlasiran 300 mg, N equals 6, or 600 mg, N equals 6, or 2 doses of placebo, N equals 9, Zerlasiran 200 mg, N equals 9, at a 4-week interval, or 300 mg, N equals 9, or 450 mg, N equals 9, at an 8-week interval. Main outcomes measures: the primary outcome was safety and tolerability. Secondary outcomes included serum levels of Zerlasiran and effects on lipoprotein A serum concentrations. Results among 37 patients in the multiple dose group: mean age, 56, SD, 10.4 years, 42%, women, 36 completed the trial. Among 14 participants with extended follow-up after single doses, 13 completed the trial. There were no serious adverse events. Median baseline lipoprotein A concentrations in the multiple dose group were 288, IQR, 199 to 352, mol/L. Median changes in lipoprotein A concentration at 365 days after single doses were 14%, IQR, 13% to 15%, for the placebo group, -30%, IQR, -51% to -18%, for the 300 mg of Zerlasiran group, and -29%, IQR, -39% to -7%, for the 600 mg dose group. After 2 doses, maximal median changes in lipoprotein A concentration were 19, IQR, -17 to 28, mol/L for the placebo group, -258, IQR, -289 to -188, mol/L for the 200 mg of Zerlasiran group, -310, IQR, -368 to -274, mol/L for the 300 mg dose group, and -242, IQR, -343 to -182, mol/L for the 450 mg dose group, with maximal median percent change of 7%, IQR, -4% to 21%, -97%, IQR, -98% to -95%, -98%, IQR, -99% to -97%, and -99%, IQR, -99% to -98%, respectively, attenuating to 0.3%, IQR, -2% to 21%, -60%, IQR, -71% to -40%, -90%, IQR, -91% to -74%, and -89%, IQR, -91% to -76%, 201 days after administration. Conclusion: Zerlasiran was well tolerated and reduced lipoprotein concentrations with infrequent administration. Next, we will be discussing articles from Annals of Internal Medicine. Association of low glomerular filtration rate with adverse outcomes at older age in a large population with routinely measured cystatin C. Background: the commonly accepted threshold of glomerular filtration rate, GFR, to define chronic kidney disease, CKD, is less than 60 ml per minute (1.73 square meters). This threshold is based partly on associations between estimated GFR, GFR, and the frequency of adverse outcomes. The association is weaker in older adults, which has created disagreement about the appropriateness of the threshold for these persons. In addition, the studies measuring these associations included relatively few outcomes and estimated GFR on the basis of creatinine level, GFR, which may be less accurate in older adults. Objective: to evaluate associations in older adults between GFR versus GFR based on creatinine and cystatin C levels, GFR size, and 8 outcomes. Design: population-based cohort study. Setting: Stockholm, Sweden, 2010 to 2019. Participants: 80 to 154 participants aged 65 years or older with outpatient creatinine and cystatin C testing. Measurements: hazard ratios for all-cause mortality, cardiovascular mortality, and kidney failure with replacement therapy, KFRT, incidence rate ratios for recurrent hospitalizations, infection, myocardial infarction or stroke, heart failure, and acute kidney injury. Results: the associations between GFR size and outcomes were monotonic, but most associations for GFR were U-shaped. In addition, GFR size was more strongly associated with outcomes than GFR. For example, the adjusted hazard ratios for 60 versus 80 ml per minute (1.73 square meters) for all-cause mortality were 1.2, 95% C, 1.1 to 1.3, for GFR cis and 1.0, C, 0.9 to 1.0, for GFR, and for KFRT they were 2.6, C, 1.2 to 5.8, and 1.4, C, 0.7 to 2.8, respectively. Similar findings were observed in subgroups, including those with a urinary albumin creatinine ratio below 30 mg/g. Limitation: no GFR measurements. Conclusion: compared with low GFR in older patients, low GFR size was more strongly associated with adverse outcomes and the associations were more uniform. Next, we will be discussing articles from Nature Medicine. Personalized neoantigen vaccine and pembrolizumab in advanced hepatocellular carcinoma, a phase half trial. Programmed cell death protein 1, PD-1, inhibitors have modest efficacy as a monotherapy in hepatocellular carcinoma, HCC. A personalized therapeutic cancer vaccine, PTCV, may enhance responses to PD-1 inhibitors through the induction of tumor-specific immunity. We present results from a single-arm, open-label, phase half study of a DNA plasmid PTCV, NOS-PV02, encoding up to 40 neoantigens co-administered with plasmid-encoded interleukin-12 plus pembrolizumab in patients with advanced HCC previously treated with a multi-tyrosine kinase inhibitor. Safety and immunogenicity were assessed as primary endpoints, and treatment efficacy and feasibility were evaluated as secondary endpoints. The most common treatment-related adverse events were injection site reactions, observed in 15 of 36, 41.6%, patients. No dose-limiting toxicities or treatment-related grade greater than or equal to 3 events were observed. The objective response rate, modified intention to treat, For response evaluation criteria in solid tumors, 1.1 was 30.6%, 11 of 36 patients, with 8.3%, 3 of 36, of patients achieving a complete response. Clinical responses were associated with the number of neoantigens encoded in the vaccine. Neoantigen-specific T-cell responses were confirmed in 19 of 22, 86.4%, evaluable patients by enzyme-linked immunosorbent spot assays. Multiparametric cellular profiling revealed active, proliferative and cytolytic vaccine-specific CD4+ and CD8+ effector T cells. T-cell receptor beta chain, TCR-beta, bulk sequencing results demonstrated vaccination-enriched T-cell clone expansion and tumor infiltration. Single-cell analysis revealed post-treatment T-cell clonal expansion of cytotoxic T-cell phenotypes. TCR complementarity determining region cloning of expanded T-cell clones in the tumors following vaccination confirmed reactivity against vaccine-encoded neoantigens. Our results support the PTCV's mechanism of action based on the induction of anti-tumor T cells and show that a PTCV plus pembrolizumab has clinical activity in advanced HCC. Next, we will be discussing articles from British Medical Journal. Use of progestogens and the risk of intracranial meningioma, National Case Control Study. Objective to assess the risk of intracranial meningioma associated with the use of selected progestogens. Design National Case Control Study. Setting French National Health Data System, Système National des Données de Santé. Participants of 108,366 women overall, 18,061 women living in France who had intracranial surgery for meningioma between January 1, 2009 and December 31, 2018. Restricted inclusion periods for intrauterine systems were deemed to be in the case group. Each case was matched to 5 controls for year of birth and area of residence, 9,305 controls. Main outcome measures selected progestogens were used: progesterone, hydroxyprogesterone, dydrogesterone, medrogestone, medroxyprogesterone acetate, pramigestone, dianogest, and intrauterine levonorgestrel. For each progestogen, use was defined by at least one dispensation within the year before the index date, within 3 years for 13.5 mg levonorgestrel intrauterine systems and 5 years for 52 mg. Conditional logistic regression was used to calculate odds ratio for each progestogen meningioma association. Results: mean age was 57.6 years, standard deviation 12.8. Analyses showed excess risk of meningioma with use of medrogestone, 42 exposed cases / 18,061 cases, 0.2%, V79 exposed controls / 9,305 controls, 0.1%, odds ratio 3.49, 95% confidence interval 2.38 to 5.10, medroxyprogesterone acetate, injectable, 9,18061, 0.05%, V11 9,305, 0.01%, 5.55, 2.27 to 13.56, and pramigestone, 83 18061, 0.5%, V225 9,305, 0.2%, 2.39, 1.85 to 3.09. This excess risk was driven by prolonged use, greater than or equal to a year. Results showed no excess risk of intracranial meningioma for progesterone, dydrogesterone, or levonorgestrel intrauterine systems. No conclusions could be drawn concerning dianogest or hydroxyprogesterone because of the small number of individuals who received these drugs. A highly increased risk of meningioma was observed for cyproterone acetate, 891 18061, 4.9%, V256 9,305, 0.3%, odds ratio 19.21, 95% confidence interval 16.61 to 22.22, nomogestral acetate, 925 18061, 5.1%, V1121 9,305, 1.2%, 4.93, 4.50 to 5.41, and clomadenone acetate, 628 18061, 3.5%, V946 9,305, 1.0%, 3.87, 3.48 to 4.30, which were used as positive controls for use. Conclusions: prolonged use of medroxystone, medroxyprogesterone acetate, and promegestone was found to increase the risk of intracranial meningioma. The increased risk associated with the use of injectable medroxyprogesterone acetate, a widely used contraceptive, and the safety of levonorgestrel intrauterine systems are important new findings. Next, we will be discussing articles from Lancet. Coronary sinus reducer for the treatment of refractory angina, Orbitocosmic, a randomized, placebo-controlled trial. Background: the coronary sinus reducer, CSR, is proposed to reduce angina in patients with stable coronary artery disease by improving myocardial perfusion. We aim to measure its efficacy, compared with placebo, on myocardial ischemia reduction and symptom improvement. Methods: Orbitocosmic was a double-blind, randomized, placebo-controlled trial conducted at 6 UK hospitals. Patients aged 18 years or older with angina, stable coronary artery disease, ischemia, and no further options for treatment were eligible. All patients completed a quantitative adenosine stress perfusion cardiac magnetic resonance scan, symptom and quality of life questionnaires, and a treadmill exercise test before entering a 2-week symptom assessment phase, in which patients reported their angina symptoms using a smartphone application, Orbita app. Patients were randomly assigned, 1-to-1, to receive either CSR or placebo. Both participants and investigators were masked to study assignment. After the CSR implantation or placebo procedure, patients entered a 6-month blinded follow-up phase in which they reported their daily symptoms in the Orbita app. At 6 months, all assessments were repeated. The primary outcome was myocardial blood flow in segments designated ischemic at enrollment during the adenosine stress perfusion cardiac magnetic resonance scan. The primary symptom outcome was the number of daily angina episodes. Analysis was done by intention to treat and followed Bayesian methodology. The study is registered with clinicaltrials.gov, NCT 04892537, and completed. Findings: between May 26, 2021, and June 28, 2023, 61 patients were enrolled, of whom 51, 44, 86% male, 7, 14% female, were randomly assigned to either the CSR group, N equals 25, or the placebo group, N equals 26. Of these, 50 patients were included in the intention to treat analysis, 24 in the CSR group, and 26 in the placebo group. 454, 57%, of 800 imaged cardiac segments were ischemic at enrollment, with a median stress myocardial blood flow of 1 middle.08 ml per minute per gram, IQR 0 middle.77 to 1 middle.41. Myocardial blood flow in ischemic segments did not improve with CSR compared with placebo, difference 0 middle.06 ml per minute per gram, 95% Cre 0 middle.09 to 0 middle.20. PR benefit equals 78 middle.8%. The number of daily angina episodes was reduced with CSR compared with placebo, OR 1 middle.40, 95% Cre 1 middle.08 to 1 middle.83, PR benefit equals 99 middle.4%. There were 2 CSR embolization events in the CSR group, and no acute coronary syndrome events or deaths in either group. Interpretation: Orbitocosmic found no evidence that the CSR improved transmural myocardial perfusion, but the CSR did improve angina compared with placebo. These findings provide evidence for the use of CSR as a further antianginal option for patients with stable coronary artery disease. Next, we will be discussing articles from Journal of Clinical Oncology. Lenvatinib plus pembrolizumab versus sunitinib in first-line treatment of advanced renal cell carcinoma, final pre-specified overall survival analysis of CLEAR, a phase 3 study. We present the final pre-specified overall survival, OS, analysis of the open-label, phase 3 CLEAR study in treatment-naive patients with advanced renal cell carcinoma, ARC. With an additional follow-up of 23 months from the primary analysis, we report results from the lenvatinib plus pembrolizumab versus sunitinib comparison of CLEAR. Treatment-naive patients with ARC were randomly assigned to receive lenvatinib, 20 mg orally once daily in 21-day cycles, plus pembrolizumab, 200 mg intravenously once every 3 weeks, or Sunitinib, 50 mg orally once daily, 4 weeks on/2 weeks off. At this data cutoff date, July 31, 2022, the OS hazard ratio, HR, was 0.79, 95% C, 0.63 to 0.99. The median OS, 95% C, was 53.7 months, 95% C, 48.7 to not estimable, NE, with Lenvatinib plus pembrolizumab versus 54.3 months, 95% C, 40.9 to NE with Sunitinib. 36-month OS rates, 95% C, were 66.4%, 95% C, 61.1 to 71.2 and 60.2%, 95% C, 54.6 to 65.2, respectively. The median progression-free survival, 95% C, was 23.9 months, 95% C, 20.8 to 27.7, with Lenvatinib plus pembrolizumab and 9.2 months, 95% C, 6.0 to 11.0, with Sunitinib, HR, 0.47, 95% C, 0.38 to 0.57. Objective response rate also favored the combination over Sunitinib, 71.3% v 36.7%, relative risk 1.94, 95% C, 1.67 to 2.26. Treatment emergent adverse events occurred in greater than 90% of patients who received either treatment. In conclusion, Lenvatinib plus pembrolizumab achieved consistent, durable benefit with a manageable safety profile in treatment-naive patients with ARC. Next, we will be discussing articles from Journal of Hepatology. Preventing Liver Disease with Policy Measures to Tackle Alcohol Consumption and Obesity, the HEPA-Health 2 Study. Background and aims. Chronic liver disease, CLD, causes 1.8% of all deaths in Europe, many of them from liver cancer. We estimated the impact of several policy interventions in France, the Netherlands, and Romania. Methods. We used a validated microsimulation model to assess 7 different policy scenarios in 2022 to 2030, a minimum unit price, MUP, of alcohol of 70 euro cents or €1, a volumetric alcohol tax, a sugar-sweetened beverage, SSB, tax, food marketing restrictions, plus 2 different combinations of these policies compared against current policies, the inaction scenario. Results. All policies reduce the burden of CLD and liver cancer. The largest impact was observed for a MUP of €1, which by 2030 would reduce the cumulative incidence of CLD by between 7.1% to 7.3% in France, the Netherlands, and Romania compared with inaction. For liver cancer, the corresponding reductions in cumulative incidence were between 4.8% to 5.8%. Implementing a package containing a MUP of 70 euro cents, a volumetric alcohol tax, and an SSB tax would reduce the cumulative incidence of CLD by between 4.29% to 4.71% and of liver cancer by between 3.47% to 3.95% in France, the Netherlands, and Romania. The total predicted reduction in healthcare costs by 2030 was greatest with the €1 MUP scenario, with a reduction for liver cancer costs of €8.18 million and €612.49 million in the Netherlands and France, respectively. Conclusions. Policy measures tackling primary risk factors for CLD and liver cancer, such as the implementation of a MUP of €1 and/or a MUP of 70 euro cents plus SSB tax, could markedly reduce the number of Europeans with CLD or liver cancer. Impact and implications. Policymakers must be aware that alcohol and obesity are the 2 leading risk factors for chronic liver disease and liver cancer in Europe, and both are expected to increase in the future if no policy interventions are made. This study assessed the potential of different public health policy measures to mitigate the impact of alcohol consumption and obesity on the general population in 3 European countries, France, the Netherlands, and Romania. The findings support introducing a €1 minimum unit price for alcohol to reduce the burden of chronic liver disease. In addition, the study shows the importance of targeting multiple drivers of alcohol consumption and obesogenic products simultaneously via a harmonized fiscal policy framework, to complement efforts being made within health systems. These findings should encourage policymakers to introduce such policy measures across Europe to reduce the burden of liver disease. The modeling methods used in this study can assist in structuring similar modeling in other regions to expand on this study's findings. Effects of tetrathiamolibdate on copper metabolism in healthy volunteers and in patients with Wilson disease. Background and aims. In Wilson disease, WD, copper accumulates in the liver and brain, causing disease. This choline tetrathiamolibdate, TTM, is a potent copper chelator that may be associated with a lower risk of inducing paradoxical neurological worsening than conventional therapy for neurologic WD. To better understand the mode of action of TTM, we investigated its effects on copper absorption and biliary excretion. Methods. In a double-blind randomized setting, hepatic 64-CHO activity was examined after orally administered 64-CHO by PET/CT in 16 healthy volunteers before and after 7 days of TTM treatment, 15 mg/d, or placebo. Oral 64-CHO was administered 1 hour after the final TTM dose. Changes in hepatic 64-CHO activity reflected changes in intestinal 64-CHO uptake. Additionally, in 4 patients with WD, the distribution of 64-CHO in venous blood, liver, gallbladder, kidney, and brain was followed after IV 64-CHO dosing for up to 68 hours before and after 7 days of TTM, 15 mg/day, using PET/MRI. Increased gallbladder 64-CHO activity was taken as evidence of increased biliary 64-CHO excretion. Results. In healthy volunteers, TTM reduced intestinal 64-CHO uptake by 82% 15 hours after the oral 64-CHO dose. In patients with WD, gallbladder 64-CHO activity was negligible before and after TTM, while TTM effectively retained 64-CHO in the blood, significantly reduced hepatic 64-CHO activity at all time points, and significantly reduced cerebral 64-CHO activity 2 hours after the intravenous 64-CHO dose. Conclusions. While we did not show an increase in biliary excretion of 64-CHO following TTM administration, we demonstrated that TTM effectively inhibited most intestinal 64-CHO uptake and retained 64-CHO in the bloodstream, limiting the exposure of organs like the liver and brain to 64-CHO. Impact and implications. This choline tetrathiamolibdate, TTM, is an investigational copper chelator being developed for the treatment of Wilson disease. In animal models of Wilson disease, TTM has been shown to facilitate biliary copper excretion. In the present human study, TTM surprisingly did not facilitate biliary copper excretion but instead reduced intestinal copper uptake to a clinically significant degree. Our study builds on our understanding of human copper metabolism and the mechanism of action of TTM. Next, we will be discussing articles from Clinical Gastroenterology. The Index of Severity for Eosinophilic Esophagitis, IC, reflects longitudinal clinicopathologic changes in children. Background and aims. The Index of Severity for Eosinophilic Esophagitis, IC, was recently developed. We aim to understand IC scores in a longitudinal pediatric cohort and to determine the relationship between IC and clinical features in children. Methods. We performed a retrospective analysis on a prospectively enrolled cohort of children at a single center who were treated as part of routine clinical care. IC was calculated at the diagnostic and follow-up endoscopies over a mean of 6.6 years. Scoring was 0 for inactive, 1 to 6 for mild, 7 to 14 for moderate, and greater than or equal to 15 for severe eosinophilic esophagitis, O. We analyzed clinical, endoscopic, and histologic features at each instance. Symptoms were analyzed at the baseline, first follow-up, and last endoscopic instance. Results. Of 67 children who met study criteria of at least 3 endoscopies over at least 2 years of follow-up time, 43%, 36%, and 21% had mild, moderate, and severe IC scores at baseline, respectively. Between the first and second endoscopic instances, there was a decrease in the group mean IC from 9.7 plus or minus 7.2 to 6.1 plus or minus 5.9, p less than 0.001. By the last instance, the overall IC score dropped to 3.9, p less than 0.001. Body mass index less than 5% and poor feeding were more common in the children with severe IC scores at baseline, and both improved by the last instance. Fibrosis was improved by the last instance biopsy, p less than 0.1. Conclusions. IC is a responsive severity metric in children treated long-term during routine clinical care. Baseline low body mass index and poor feeding were more common in children with severe IC scores. Alcoholic foamy degeneration, an entity resembling alcohol-associated hepatitis, diagnosis, prognosis, and molecular profiling. Background and names. Alcoholic foamy degeneration, AFD, is a condition with similar clinical presentation to alcohol-associated hepatitis, A, but with a specific histologic pattern. Information regarding the prevalence and prognosis of AFD is scarce, and there are no tools for a non-invasive diagnosis. Methods. A cohort of patients admitted to the Hospital Clinic of Barcelona for clinical suspicion of A who underwent liver biopsy was included. Patients were classified as AFD, A, or other findings, according to histology. Clinical features, histology, and genetic expression of liver biopsy specimens were analyzed. The accuracy of National Institute on Alcohol Abuse and Alcoholism criteria and laboratory parameters for differential diagnosis were investigated. Results. Of 230 patients with a suspicion of A, 8% met histologic criteria for AFD, 184, 80%, had definite A, and 28, 12%, had other findings. In patients with AFD, massive steatosis was more frequent and the fibrosis stage was lower. AFD was characterized by downregulation of liver fibrosis and inflammation genes and upregulation of lipid metabolism and mitochondrial function genes. Patients with AFD had markedly better long-term survival, 100% versus 57% in AFD versus A, p equals 0.002, despite not receiving corticosteroid treatment, even in a model for end-stage liver disease matched sensitivity analysis. Serum triglyceride levels had an area under the receiver operating characteristic of 0.886, 95% C, 0.807 to 0.964, for the diagnosis of AFD, whereas the National Institute on Alcohol Abuse and Alcoholism criteria performed poorly. A one-step algorithm using triglyceride levels of 225 mg/dl, sensitivity 0.77, specificity 0.90, and Newton index 0.67 is proposed for differential diagnosis. Conclusions. AFD in the setting of suspicion of A is not uncommon. A differential diagnosis is important because prognosis and treatment differ largely. Triglyceride levels successfully identify most patients with AFD and may be helpful in decision-making. Modified release phosphatidylcholine, LTO2, for ulcerative colitis, 2 double-blind, randomized, placebo-controlled trials. Background and names. The aim of this study was to evaluate the efficacy of LTO2, a novel modified release phosphatidylcholine, PC, formulation, for induction and maintenance of remission in patients with mild to moderate ulcerative colitis, UC, and inadequate response to mesalamine. Methods. LTO2 was evaluated in a multi-center double-blind, randomized, placebo-controlled study comprising a 12-week induction trial, PCG2, followed by a 48-week maintenance trial, PCG4. In PCG2, patients were randomized 1:1:1 to treatment with 0.8 grams LTO2 4 times daily, QID, 1.6 grams LTO2 twice daily, BID, or placebo, respectively. All patients continued to take a standard dose of oral mesalamine, greater than or equal to 2.4 grams/day. The primary endpoint in PCG2 was deep remission. Patients achieving remission at week 12 were randomly assigned 2:1:1 to 1.6 grams LTO2 BID, placebo, or 500 mg mesalamine, 3 times daily, respectively. In PCG4, the primary endpoint was remission at 48 weeks. Results. PCG2 was terminated early for futility after a pre-specified interim analysis. 466 patients, of 762 planned, were randomized. There was no statistically significant difference in deep remission at week 12, placebo, 13.5%, LTO2 bid, 14.2%, LTO2 kid, 9.7%. In PCG4, 150 patients, of approximately 400 planned, were randomized. There was no statistically significant difference in remission rates at week 48, LTO2 bid, 49.3%, mesalamine, 50.0%, placebo, 43.2%. LTO2 was safe. Conclusions. Despite prior evidence of beneficial effects of PC in phase 2 trials, our induction study with LTO2 in patients with mild to moderate UC was terminated prematurely for futility. Signals of efficacy in maintenance therapy require confirmation in an adequately powered maintenance trial. LTO2 was safe and well tolerated. Quality of life and bidirectional gut-brain interactions in irritable bowel syndrome from adolescence to adulthood. Backgrounds and aims. Reports on cross-sectional and longitudinal associations between health-related quality of life, HERCAL, psychological distress, and irritable bowel syndrome, IBS, in the adolescent and young adult general population are few. We aim to describe cross-sectional associations between HERCAL and IBS in adolescence and young adulthood, and examine bidirectional gut-brain interactions in the transition from childhood to adulthood. Methods. We included 3,391 subjects from a prospective birth cohort study, with data on IBS at 16 years of age and 24 years of age. IBS was assessed using the pediatric Rome 3, 16 years of age, and the adult Rome 4, 24 years of age, diagnostic questionnaires. HERCAL and psychological distress were assessed through EQ5D. Sex-adjusted logistic regression models were used to examine associations between overall HERCAL/psychological distress at 16 years of age and new-onset IBS at 24 years of age, brain-gut, and between IBS at 16 years of age and new-onset psychological distress at 24 years of age, gut-brain. Results. In subjects with versus without IBS at 16 and 24 years of age, overall HERCAL, EQ visual analog scale, EQ5D index value, was lower, and it was more common reporting problems in 4 of 5 EQ5D dimensions, all p less than 0.05. EQ5D index value at 16 years of age was inversely associated, odds ratio or 0.1, 95% confidence interval, c. 0.01 to 0.6, and psychological distress at 16 years of age was positively associated, or 1.6, 95% c. 1.2 to 2.3, with new onset IBS at 24 years of age. Having any abdominal pain-related disorder of gut-brain interaction at 16 years of age was associated with new onset psychological distress at 24 years of age, or 1.7, 95% c. 1.2 to 2.5. Conclusions. Adolescents and young adults with IBS in the general population have impaired HERCAL. Bidirectional gut-brain interactions are relevant for symptom generation in abdominal pain-related disorders of gut-brain interaction, and for HERCAL impairment and psychological distress in the transition from childhood to adulthood. Next, we will be discussing articles from Clinical Liver Disease. Acceptability of hepatitis C screening and treatment during pregnancy in pregnant women in Egypt, Pakistan, and Ukraine, a cross-sectional survey. Chronic hepatitis C, HCV, in women of childbearing age is a major public health concern, with 15 million women aged 15 to 49 years living with HCV globally in 2019. Evidence suggests HCV in pregnancy is associated with adverse pregnancy and infant outcomes. This includes 6% risk of infants acquiring HCV vertically, and this is the leading cause of HCV in children globally. However, few countries offer routine universal antenatal HCV screening, and direct-acting antivirals, DAAs, are not approved for pregnant or breastfeeding women, although small clinical trials are ongoing. We conducted a survey of pregnant and postpartum women in 3 high HCV burden lower middle income countries to assess the acceptability of universal antenatal HCV screening and DAA treatment in the scenario that DAAs are approved for use in pregnancy. Pregnant and postpartum women attending antenatal clinics in Egypt, Pakistan, and Ukraine were invited to complete a survey and provide demographic and clinical data on their HCV status. Among the 630 women included, N equals 210 per country, 73% were pregnant and 27% postpartum, 27% were ever HCV antibody or PCR positive. Overall, 586, 93%, reported acceptability of universal antenatal HCV screening and 544, 88%, would take DAAs in pregnancy, 92%, 98%, and 73% in Egypt, Pakistan, and Ukraine, respectively. Most said they would take DAAs in pregnancy to prevent vertical acquisition and other risks for the baby, and a smaller proportion would take DAAs for maternal cure. Our findings suggest that should DAAs be approved for use in pregnancy, the uptake of both HCV screening and DAA treatment may be high in women living in lower middle-income countries. Next, we will be discussing articles from Clinical Infectious Diseases. Is short-course antibiotic therapy suitable for Pseudomonas aeruginosa bloodstream infections in oncohematology patients with febrile neutropenia? Results of a multi-institutional analysis. Background. Several studies have suggested that short-course antibiotic therapy was effective in Pseudomonas aeruginosa, PA, bloodstream infections, BSI, in immunocompetent patients. But similar studies in patients with hematological malignancies were rare. Methods. This cohort study included oncohematology patients at 2 hematology centers in China. Inverse probability of treatment weighting was used to balance the confounding factors. Multivariate regression model was used to evaluate the effect of short-course antibiotic therapy on clinical outcomes. Results. In total, 434 patients met eligibility criteria, short course, 7 to 11 days, N equals 229, prolonged, 12 to 21 days, N equals 205. In the weighted cohort, the univariate and multivariate analysis indicated that short-course antibiotic therapy had similar outcomes to the prolonged course. The recurrent PA infection at any site or mortality within 30 days of completing therapy occurred in 8, 3.9%, patients in the short-course group and in 10, 4.9%, in the prolonged course group, p equals 0.979. The recurrent infection within 90 days occurred in 20, 9.8%, patients in the short course group and in 13, 6.3%, patients in the prolonged course group, p equals 0.139, and the recurrent fever within 7 days occurred in 17, 8.3%, patients in the short course group and in 15, 7.4%, in the prolonged course group, p equals 0.957. On average, patients who received short-course antibiotic therapy spent 3.3 fewer days in the hospital, p less than 0.001. Conclusions. In the study, short-course therapy was non-inferior to prolonged course therapy in terms of clinical outcomes. However, due to its biases and limitations, further prospective randomized controlled trials are needed to generalize our findings. Bartonella quintana endocarditis, a systematic review of individual cases. Background. Bartonella quintana is a louse-borne bacterium that remains a neglected cause of endocarditis in low-resource settings. Our understanding of risk factors, clinical manifestations, and treatment of B. quintana endocarditis are biased by older studies from high-income countries. Methods. We searched PubMed Central, Medline, Scopus, Embase, EBSCO, CABI, Global Health, Web of Science and international trial registers for articles published before March 2023 with terms related to Bartonella quintana endocarditis. We included articles containing case-level information on B. quintana endocarditis and extracted data related to patient demographics, clinical features, diagnostic testing, treatment, and outcome. Results. A total of 975 records were identified, of which 569 duplicates were removed prior to screening. In total, 84 articles were eligible for inclusion, describing a total of 167 cases. Infections were acquired in 40 different countries, 62 cases, 37.1%, were acquired in low and middle-income countries, mix. Disproportionately more female and pediatric patients were from a mix. More patients presented with heart failure, N equals 70/167, 41.9%, than fever, N equals 65/167, 38.9%. Mean time from symptom onset to presentation was 5.1 months. Also, 25.7% of cases, N equals 43/167, were associated with embolization, most commonly to the spleen and brain. 65.5% of antimicrobial regimens included doxycycline. The vast majority of cases underwent valve replacement surgery, N equals 154/167, 98.0%. Overall case fatality rate was 9.6%, N equals 16/167. Conclusions. Biquintana endocarditis has a global distribution, and long delays between symptom onset and presentation frequently occur. Improved clinician education and diagnostic capacity are needed to screen at-risk populations and identify infection before Socioeconomic and demographic risk factors for SARS-CoV-2 seropositivity among healthcare workers in a UK hospital, a prospective cohort study. Background. To protect healthcare workers, HCWs, from the consequences of disease due to severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, it is necessary to understand the risk factors that drive exposure and infection within hospitals. Insufficient consideration of key socioeconomic variables is a limitation of existing studies that can lead to bias and residual confounding of proposed risk factors for infection. Methods. The COSTARS study prospectively enrolled 3,679 HCWs between April 2020 and September 2020. We used multivariate logistic regression to comprehensively characterize the demographic, occupational, socioeconomic, and environmental risk factors for SARS-CoV-2 seropositivity. Results. After adjusting for key confounders, relative household overcrowding, odds ratio, or 1.4, 95% confidence interval, C, 1.1 to 1.9, P equals 0.006, Black, British, Caribbean, or African ethnicity, or 1.7, 95% C, 1.2 to 2.3, P equals 0.003, increasing age, ages 50 to 60 years, or 1.8, 95% C, 1.3 to 2.4, P less than 0.001, lack of access to sick pay, or 1.8, 95% C, 1.3 to 2.4, P less than 0.001. Conclusions. Socioeconomic and demographic factors outside the hospital were the main drivers of infection and exposure to SARS-CoV-2 during the first wave of the pandemic in an urban pediatric referral hospital. Overcrowding and out-of-hospital SARS-CoV-2 contact are less amenable to intervention. However, lack of access to sick pay among externally contracted staff is more easily rectifiable. Our findings suggest that providing easier access to sick pay would lead to a decrease in SARS-CoV-2 transmission and potentially that of other infectious diseases in hospital settings. Next, we will be discussing articles from Journal of Infectious Diseases. Effectiveness of BNT162b2-BA. 4/5 bivalent mRNA vaccine against symptomatic COVID-19 among immunocompetent individuals testing at a large U.S. retail pharmacy. Background. Data on the effectiveness of BA. 4/5 bivalent vaccines stratified by age and prior infection are lacking. Methods. This test-negative study used data from individuals greater than or equal to 5 years of age testing for SARS-CoV-2 with symptoms, September 15, 2022 to January 31, 2023, at a large national retail pharmacy chain. The exposure was receipt of 2 to 4 wild-type doses and a BNT162b2-BA. 4/5 bivalent vaccine, greater than 2 months since last wild-type dose. The outcome was a positive SARS-CoV-2 test. Absolute versus unvaccinated and relative versus 2 to 4 wild-type doses, vaccine effectiveness, BA, were calculated as 1 minus adjusted odds ratio from logistic regression, times 100. BA was stratified by age and self-reported prior infection. Results. Overall, 307,885 SARS-CoV-2 tests were included, 7,916 aged 5 to 11, 16,329 aged 12 to 17, and 283,640 aged greater than or equal to 18 years. SARS-CoV-2 positivity was 39%, 21% were unvaccinated, 70% received 2 to 4 wild-type doses with no bivalent vaccine, and 9% received a BNT162b2 4/5 bivalent dose. At a median of 1 to 2 months after BNT162b2 4/5 bivalent vaccination, depending on age group, absolute BA was 22% to 60%, and was significantly higher among those reporting prior infection, range 55% to 79%, than not, range no protection to 50%. Relative VA was 31% to 64%. Conclusions: BNT162b2 4/5 bivalent showed early additional protection against Omicron-related symptomatic COVID-19, with hybrid immunity offering greater Next we will be discussing articles from Journal of Clinical Rheumatology. Transition from Pediatric to Adult Rheumatology Care, an exploratory study from Latin America. Background/purpose. Adequate transition from pediatric to adult care is associated with better adherence to treatment and better outcomes in pediatric patients with chronic diseases. There are little data on transition programs, outcomes, use of transition guidelines, and available tools in pediatric rheumatology centers from Latin America, LATAM. In this study, we describe the characteristics of transition programs from 3 pediatric rheumatology centers. We also introduced results of the first survey examining the transition experience in countries from LATAM. Methods. The experience and implementation process of transition programs from 3 pediatric rheumatology centers are described. A survey based on a questionnaire created by Chira et al. J. Rheumatol. 2014 41 to 768 to 779 from the Childhood Arthritis and Rheumatology Research Alliance was also administered to pediatric rheumatology centers from LATAM. Results: a total of 49, 68%, pediatric rheumatologists answered the survey. Most centers do not have an official and written transition program and reported a need for more tools and resources in their services to facilitate the transition experience. Conclusions: transition guidelines culturally tailored to developing countries are needed in LATAM. Next we will be discussing articles from Arthritis and Rheumatology. Polyrefractory rheumatoid arthritis, an uncommon subset of difficult-to-treat disease with distinct inflammatory and non-inflammatory phenotypes. Objective: to investigate the prevalence of polyrefractory rheumatoid arthritis, RA, defined as failure of all biological, B/targeted synthetic, TS, disease-modifying drugs, MARDs. To further investigate whether patients with persistent inflammatory refractory RA, PIRA, and non-inflammatory refractory RA, NIRA, determined by objective ultrasound, US, synovitis, have distinct clinical phenotypes in both Euler difficult-to-treat RA, D2T RA, and polyrefractory RA groups. Methods: a cross-sectional study of 1,591 patients with RA on B/SMARDs that evaluated D2T RA criteria and subclassified as polyrefractory if inefficacy/toxicity to at least one drug of all classes. PIRA was defined if US synovitis in one or more swollen joint and NIRA if absent. Univariate tests and multivariate logistic regression were conducted to investigate factors associated with polyrefractory, PIRA, and NIRA phenotypes. Results: 122 of 1,591 were excluded due to missing data. 247 of 1,469, 16.8%, had D2T RA and only 40 of 1,469, 2.7%, polyrefractory RA. This latter group had higher disease activity score 28C reactive protein, CRP, median 5.4 versus 5.02, p less than 0.05, CRP levels, median 13 versus 5 mg/L, p less than 0.01, and smoking, ever, rates, 20% versus 4%, p less than 0.01, compared with other D2T patients. Smoking was associated with polyrefractory RA, Odds ratio 5.067, 95% C 1.774 to 14.472, P equals 0.002. Of 107 patients with D2-TRA with recent US, 61, 57%, were PIRA and 46, 43%, NIRA. Patients with NIRA had elevated body mass index, median 30 versus 26, P less than 0.001, and higher fibromyalgia prevalence, 15% versus 3%, P less than 0.05, lower swollen joint count, median, 2 versus 5, P less than 0.001, and lower CRP levels, 5 versus 10, P less than 0.01. Conclusion. Only 2.7% of D2-TRA failed all classes of B/SMARDs. Among D2-TRA, less than 60% had objective signs of inflammation, representing a target for innovative strategies. Next, we will be discussing articles from Circulation. Clinical and prognostic implications of right ventricular uptake on bone scintigraphy in transthyretin amyloid cardiomyopathy. Background. The extent of myocardial bone tracer uptake with technetium pyrophosphate, hydroxymethylene diphosphonate, and 3,3-diphosphono-1,2-propanatocarboxylate in transthyretin amyloid cardiomyopathy, ATTR-CM, might reflect cardiac amyloid burden and be associated with outcome. Methods. Consecutive patients with ATTR-CM who underwent diagnostic bone tracer scintigraphy with acquisition of whole-body planar and cardiac single-photon emission computed tomography (SPECT) images from the National Amyloidosis Center and 4 Italian centers were included. Cardiac uptake was defined according to the Perugini classification: 0 equals absent cardiac uptake, 1 equals mild uptake less than bone, 2 equals moderate uptake equal to bone, and 3 equals high uptake greater than bone. Extent of right ventricular, RV, uptake was defined as focal, basal segment of the RV free wall only, or diffuse, extending beyond basal segment, on the basis of SPECT imaging. The primary outcome was all-cause mortality. Results. Among 1,422 patients with ATTR-CM, RV uptake accompanying left ventricular uptake was identified by SPECT imaging in 100% of cases at diagnosis. Median follow-up in the whole cohort was 34 months, interquartile range, 21 to 50 months, and 494 patients died. By Kaplan-Meier analysis, diffuse RV uptake on SPECT imaging, N equals 936, was associated with higher all-cause mortality compared with focal, N equals 486, RV uptake, 77.9% versus 22.1%, P less than 0.001, whereas Perugini grade was not associated with survival, P equals 0.27 in grade 2 versus grade 3. On multivariable analysis, after adjustment for age at diagnosis, hazard ratio, HR, 1.03, 95% C, 1.02 to 1.04, P less than 0.001, presence of the P. V142I, TTR variant, HR, 1.42, 95% C, 1.20 to 1.81, P equals 0.004, National Amyloidosis Center stage, each category, P less than 0.001, stroke volume index, HR, 0.99, 95% C, 0.97 to 0.99, P equals 0.043, E/E, HR, 1.02, 95% C, 1.007 to 1.03, P equals 0.004, right atrial area index, HR, 1.05, 95% C, 1.02 to 1.08, P equals 0.001, and left ventricular global longitudinal strain, HR, 1.06, 95% C, 1.03 to 1.09, P less than 0.001, diffuse RV uptake on SPECT imaging, HR, 1.60, 95% C, 1.26 to 2.04, P less than 0.001, remained an independent predictor of all-cause mortality. The prognostic value of diffuse RV uptake was maintained across each National Amyloidosis Center stage and in both wild-type and hereditary ATTR-CM, p less than 0.001 and p equals 0.02, respectively. Conclusions. Diffuse RV uptake of bone tracer on SPECT imaging is associated with poor outcomes in patients with ATTR-CM and is an independent prognostic marker at diagnosis. Next, we will be discussing articles. American College of Cardiology. FFR Guidance for Complete Non-Culprit Revascularization. Description. The goal of the trial was to evaluate physiology-guided complete revascularization compared with usual care among patients with ST segment elevation myocardial infarction, STEMI, and multivessel coronary disease who underwent culprit vessel percutaneous coronary intervention (PCI). Study design. Randomized. Parallel. Blinded. Patients with STEMI who underwent culprit vessel PCI were randomized to physiology-guided revascularization of the non-culprit lesions, N equals 764, versus usual care, N equals 778. Coronary physiology was assessed by fractional flow reserve, FFR. Total number of enrollees, 1,542. Duration of follow-up, median 4.8 years. Mean patient age, 65 years. Percentage female, 21%. Percentage with diabetes, 16%. Inclusion criteria. STEMI and culprit vessel PCI greater than or equal to 1 non-culprit lesion. Exclusion criteria. Previous coronary artery bypass grafting. Left main disease. Cardiogenic shock. Other salient features/characteristics. FFR less than or equal to 0.8 in non-culprit lesions, 47%. Complete revascularization was achieved in 94% of those with documented ischemia. Principal findings? The primary outcome, death, ME, or unplanned revascularization, at a median of 4.8 years occurred in 19.0% of the complete revascularization group versus 20.4% of the usual care group, p equals 0.53. Secondary outcomes. Death or ME, 16.5% of the complete revascularization group versus 15.3% of the usual care group, p equals not significant, NS unplanned revascularization, 9.2% of the complete revascularization group versus 11.7% of the usual care group, p equals NS interpretation. Among patients with STEMI who underwent culprit vessel PCI, physiology-guided revascularization of non-culprit lesions failed to improve clinical outcomes. Complete revascularization did not reduce the primary outcome, death, ME, or unplanned, at a median of 4.8 years. Physiology-guided revascularization also failed to reduce death or ME and failed to reduce unplanned revascularization compared with usual care. These findings are different from several previous trials. The complete trial documented a lower incidence of cardiovascular death or ME with angiography-guided complete revascularization. The FIRE trial documented a lower incidence of cardiovascular death or ME with physiology-guided complete revascularization. Next, we will be discussing articles from journals of the American College of Cardiology. Variation in health status with invasive versus conservative management of chronic coronary disease. Background. The ischemia trial found that patients with chronic coronary disease randomized to invasive strategy had better health status than those randomized to conservative strategy. It is unclear how best to translate these population-level results to individual patients. Objectives. The authors sought to identify patient characteristics associated with health status from invasive and conservative strategies, and develop a prediction algorithm for shared decision-making. Methods. 1-year disease-specific health status was assessed in ischemia with the Seattle Angina Questionnaire, SAQ, Summary Score, SOC-SS, and angina frequency, physical limitations, PL, and quality of life, QL, domains, range 0 to 100, higher equals less angina/better health status. Results. Among 4,617 patients from 320 sites in 37 countries, mean SOC-SS was 74.1 plus or minus 18.9 at baseline and 85.7 plus or minus 15.6 at 1 year. Lower baseline SOC-SS and younger age were associated with better 1-year health status with invasive strategy, P interaction equals 0.009 and P interaction equals 0.004, respectively. For the individual domains, there were significant treatment interactions for baseline SOC score, angina frequency, PL, age, PL, QL, anterior ischemia, PL, and number of baseline antianginal medications, QL, with more benefit of invasive in patients with worse baseline health status, younger age, anterior ischemia, and on more antianginal medications. Parsimonious prediction models were developed for 1-year SOC domains with invasive or conservative strategies to support shared decision-making. Conclusions. In the management of chronic coronary disease, individual patient characteristics are associated with 1-year health status, with younger age and poorer angina-related health status showing greater benefit from invasive management. This prediction algorithm can support the translation of the ischemia trial results to individual patients. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Effect and interactions of BRAF on lymph node metastasis in papillary thyroid carcinoma with Hashimoto thyroiditis. Context. The role of BRAF proto-oncogene, BRAF, in papillary thyroid carcinoma, PTC, with Hashimoto thyroiditis, height, is unknown. Objective. We aim to explore risk factors affecting lymph node, LANE, metastasis, and interaction effect of BRAF in PTC patients with height. Methods. We retrospectively collected the data of 994 PTC patients with height who underwent surgery at the West China Hospital. We analyzed the correlations between preoperative characteristics and LANE metastasis in overall and different BRAF 600E mutation patients. Logistic regression was applied to analyze the risk factors for LANE metastasis. Finally, we performed an interaction effect analysis to identify the interaction effect of BRAF. Results. The overall LANE metastasis rate was 52.71%, 524,994. The overall BRAF mutation rate was 26.9%, 268,994. BRAF mutation rates were significantly different in LANE metastasis and non-metastasis patients, 31.7% versus 21.5%, p less than 0.001. In all 994 patients, age, body mass index, BMI, hypertension, tumor maximum diameter, BRAF mutation, tumor location, aspect ratio, calcification, and extrathyroidal invasion were risk factors for LANE metastasis, p less than 0.05. In BRAF mutant patients, smoking, hypertension, maximum diameter, calcification, and multifocality were risk factors for LANE metastasis, p less than 0.05. In BRAF wild-type patients, age, BMI, maximum diameter, tumor location, aspect ratio, tumor shape, calcification, and extrathyroidal invasion were risk factors, p less than 0.05. Additionally, we found statistically significant interactions between BRAF and BMI, hypertension, maximum diameter, and calcification, p less than 0.05, suggesting the potential interaction effect of BRAF. Conclusion. BRAF is a risk factor for LANE metastasis in PTC with height. Meanwhile, BRAF can interact with age, BMI, hypertension, and calcification, which together influence LANE metastasis. Metabolic profiles of type 2 diabetes and their association with renal complications. Context. The components of metabolic syndrome, METS, are interrelated and associated with renal complications in patients with type 2 diabetes, T2D. Objective. We aim to reveal prevalent metabolic profiles in patients with T2D and identify which metabolic profiles were risk markers for renal progression. Methods. A total of 3,556 participants with T2D from a hospital, derivation cohort, and 931 participants with T2D from a community survey, external validation cohort, were included. The primary outcome was the onset of diabetic kidney disease, DKD, and secondary outcomes included estimated glomerular filtration rate, EGFR, decline, macroalbuminuria, and end-stage renal disease, ESRD. In the derivation cohort, Clusters were identified using the 5 components of METS, and their relationships with the outcomes were assessed. To validate the findings, participants in the validation cohort were assigned to clusters. Multivariate odds ratios, ORs, of the primary outcome were evaluated in both cohorts, adjusted for multiple covariates at baseline. Results. In the derivation cohort, 6 clusters were identified as metabolic profiles. Compared with Cluster 1, Cluster 3, severe hyperglycemia, had increased risks of DKD, hazard ratio, HR 95% C, 1.72, 1.39 to 2.12, macroalbuminuria, 2.74, 1.84 to 4.08, ESRD, 4.31, 1.16 to 15.99, and EEG for decline, p less than 0.001. Cluster 4, moderate dyslipidemia, had increased risks of DKD, 1.97, 1.53 to 2.54, and macroalbuminuria, 2.62, 1.61 to 4.25. In the validation cohort, clusters 3 and 4 were replicated to have significantly increased risks of DKD, adjusted ORs, 1.24, 1.07 to 1.44, and 1.39, 1.03 to 1.87. Conclusion. We identified 6 prevalent metabolic profiles in patients with T2D. Severe hyperglycemia and moderate dyslipidemia were validated as significant risk markers for DKD. Next, we will be discussing articles from Neurology. Remote ischemic conditioning with medical management or reperfusion therapy for acute ischemic stroke, a systematic review and meta-analysis. Background and objectives. Remote ischemic conditioning, RIC, is a low-cost, accessible, and non-invasive neuroprotective treatment strategy, but its efficacy and safety in acute ischemic stroke are controversial. With the publication of several randomized controlled trials, RCTs, and the recent results of the RESIST trial, it may be possible to identify the patient population that may, or may not, benefit from RIC. This systematic review and meta-analysis aims to evaluate the effectiveness and safety of RIC in patients with ischemic stroke receiving different treatments by pooling data of all randomized controlled studies to date. Methods. We searched the PubMed, Embase, Cochrane, Elsevier, and Web of Science databases to obtain articles in all languages from inception until May 25, 2023. The primary outcome was the modified Rankin scale, MISS, score at the specified endpoint time in the trial. The secondary outcomes were change in NIH stroke scale, NICE, and recurrence of stroke events. The safety outcomes were cardiovascular events, cerebral hemorrhage, and mortality. The quality of articles was evaluated through the Cochrane Risk Assessment Tool. This study was registered in Prospero, CRD 420234300073. Results. There were 7,657 patients from 22 RCTs included. Compared with the control group, patients who received RIC did not have improved MISS functional outcomes, regardless of whether they received medical management, reperfusion therapy with intravenous thrombolysis, IVT, or mechanical thrombectomy, MOUNT. In the medical management group, patients who received RIC had decreased incidence of stroke recurrence, risk ratio 0.63, 95% C 0.43 to 0.92, p equals 0.02, and lower follow-up NICE score by 1.72 points compared with the control group, p less than 0.000001. There was no increased risk of adverse events including death or cerebral hemorrhage in the IVT or medical management group. Discussion. In patients with ischemic stroke who are not eligible for reperfusion therapy, RIC did not affect MISS functional outcomes but significantly improved the NICE score at the follow-up endpoint and reduced stroke recurrence, without increasing the risk of cerebral hemorrhage or death. In patients who received IVT or MOUNT, the benefit of RIC was not observed. Statin initiation and risk of incident Alzheimer's disease and cognitive decline in genetically susceptible older adults. Background and objectives. The association of statin initiation with incident Alzheimer's disease AD dementia and cognitive decline by the epsilon 4 allele is unknown. Our objective was to examine whether the association of statin initiation with incident AD dementia and cognitive decline differs by the epsilon 4 allele. Methods. This population-based longitudinal cohort study was conducted in 4 urban communities in Chicago, Illinois, United States, consisting of 4,807 participants. Statin initiation is based on the inspection of medications during home assessments. Clinical diagnosis for incident AD used the NINCD-SADRDA criteria, and longitudinal measurements of global cognition consisted of episodic memory, perceptual speed, and the mini mental state examination tests. Results. The study participants had a mean age of 72 years, consisting of 63% female individuals and 61% non-Hispanic Black individuals. During the study period, 1,470, 31%, participants reported statin initiation. In a covariate-adjusted competing risk model, statin initiation was associated with a reduced risk of incident clinical AD, hazard ratio, HR, 0.81, 95% C 0.70 to 0.94, compared with non-users. This association was statistically significantly lower, P interaction equals 0.015, among participants with the AP epsilon 4 allele, HR 0.60, 95% C 0.49 to 0.74, compared with those without the AP epsilon 4 allele, HR 0.96, 95% C 0.82 to 1.12. The annual decline in global cognition, beta equals 0.021, 95% C 0.007 to 0.034, and episodic memory, beta equals 0.020, 95% C 0.007 to 0.033, was also substantially slower among participants with the AP epsilon 4 allele after statin initiation compared with non-users. However, the association of statin initiation with cognitive decline was not significant among those without the AP epsilon 4 allele. Discussion. Our findings suggest that statins might be associated with a lower risk of incident AD among individuals with the AP epsilon 4 allele. The benefits of statin therapy need further consideration in randomized clinical trials, especially among those with the AP epsilon 4 allele. Next, we will be discussing articles from CHEST. Use of quantitative CT imaging to identify bronchial thermoplasty responders. Background. Bronchial thermoplasty (BT) is a treatment for patients with poorly controlled, severe asthma. However, predictors of treatment response to BT are defined poorly. Research question. Do baseline radiographic and clinical characteristics exist that predict response to BT? Study design and methods. We conducted a longitudinal prospective cohort study of participants with severe asthma receiving BT across 8 academic medical centers. Participants received 3 separate BT treatments and were monitored at 3-month intervals for 1 year after BT. Similar to prior studies, a positive response to BT was defined as either improvement in asthma control test results of greater than or equal to 3 or asthma quality of life questionnaire of greater than or equal to 0.5. Regression analyses were used to evaluate the association between pretreatment clinical and quantitative CT scan measures with subsequent BT response. Results. From 2006 through 2017, 88 participants received BT, with 70 participants, 79.5%, identified as responders by asthma control test or asthma quality of life questionnaire criteria. Responders were less likely to undergo an asthma-related ICU admission in the prior year, 3% versus 25%, p equals 0.01. On baseline quantitative CT imaging, BT responders showed less air trapping percentage, or 0.90, 95% C, 0.82 to 0.99, p equals 0.03, a greater Jacobian determinant, or 1.49, 95% C, 1.05 to 2.11, greater SD of the Jacobian determinant, or 1.84, 95% C, 1.04 to 3.26, and greater anisotropic deformation index, or 3.06, 95% C, 1.06 to 8.86. Interpretation. To our knowledge, this is the largest study to evaluate baseline quantitative CT imaging and clinical characteristics associated with BT response. Our results show that preservation of normal lung expansion, indicated by less air trapping, a greater magnitude of isotropic expansion, and greater within-lung spatial variation on quantitative CT imaging, were predictors of future BT response. Individual risk factors of PM2.5 associated with wintertime mortality in urban patients with COPD background. Air pollution contributes to premature mortality, but potential impacts differ in populations with existing disease, particularly for individuals with multiple risk factors. Although COPD increases vulnerability to air pollution, individuals with COPD and other individual risk factors are at the intersection of multiple risks, and may be especially susceptible to the effect of acute outdoor air pollution. Research question: what is the association between wintertime air pollution and mortality in patients with COPD and the modifying role of individual risk factors? Study design and methods. This study evaluated 19,243 deceased veterans with prior COPD diagnosis who had resided in 25 U.S. metropolitan regions, 2016 to 2019. Electronic health records included patient demographic characteristics, smoking status, and comorbidities such as asthma, coronary artery disease, CAD, obesity, and diabetes. Using geocoded addresses, individuals were assigned wintertime fine particulate matter smaller than 2.5 g in diameter, PM2.5, and nitrogen dioxide air pollution exposures. Associations between acute air pollution and mortality were estimated by using a time-stratified case crossover design with a conditional logistic model, and individual risk differences were assessed according to stratified analysis. Results: A 1.05, 95% C, 1.02 to 1.09, mortality risk was estimated for each 10 g/m3 increase in daily wintertime PM2.5. Older patients and Black individuals displayed elevated risk. Obesity was a substantial air pollution-related mortality risk factor, or 1.11, 95% C, 1.01 to 1.23, and the estimated risk for individuals with obesity plus CAD or obesity plus diabetes was 16% higher. Interpretation: wintertime PM2.5 exposure was associated with elevated mortality risk in people with COPD, but individuals with multiple comorbidities, notably obesity, had high vulnerability. Our study suggests that obesity, CAD, and diabetes are understudied modifiers of air pollution-related risks for people with existing COPD. High-resolution CT scan fibrotic patterns in stage 4 pulmonary sarcoidosis. Background: different patterns of fibrosis on high-resolution CT scans, HRCT, have been associated with reduced survival in some interstitial lung diseases. Nothing is known about HRCT scan patterns and survival in sarcoidosis. Research question: will a detailed description of the extent and pattern of HRCT scan fibrosis in patients with stage 4 pulmonary sarcoidosis impact pulmonary function and survival? Study design and methods. 240 patients with stage 4 sarcoidosis at 2 large tertiary institutions were studied. The earliest HRCT scan with fibrosis was reviewed for extent of fibrosis, less than 10%, 10% to 20%, and greater than 20%, and presence of bronchiectasis, upper lobe fibrocystic changes, basal subpleural honeycombing, ground glass opacities, GGOs, large bullae, and mycetomas. Presence of sarcoidosis-associated pulmonary hypertension, SAPH, and pulmonary function testing performed within 1 year of HRCT were recorded. Patients were followed up until last clinic visit, death, or lung transplantation. Results: the mean age was 58.4 years. 74% were Black, 63% were female, and mean follow-up was 7.4 years. Death or LT occurred in 53 patients, 22%. 31% had greater than 20% fibrosis, 25% had 10% to 20% fibrosis, and 44% had less than 10% fibrosis. The most common HRCT abnormalities were bronchiectasis, 76%, upper lobe fibrocystic changes, 36%, and GGOs, 28%. 12% had basal subpleural honeycombing, and 32% had SOF. Patients with greater than 20% fibrosis had more severe pulmonary impairment, were more likely to have SOF, 53%, and had worse survival, 44% mortality, p less than 0.001. Upper lobe fibrocystic changes, basal subpleural honeycombing, and large bullae were associated with worse pulmonary function and worse survival. Patients with basal subpleural honeycombing had the worst pulmonary function and survival, 55% mortality, p less than 0.001. GGOs were associated with worse pulmonary function but not worse survival, and mycetomas were associated with worse survival but not worse pulmonary function. A Cox proportional hazards model indicated that basal subpleural honeycombing, hazard ratio, 7.95, diffusion capacity for carbon monoxide less than 40%, HR, 5.67, and white race, hazard ratio, 2.61, were independent predictors of reduced survival. Interpretation: HRCT scan features of fibrotic pulmonary sarcoidosis had an impact on pulmonary function and survival. Presence of greater than 20% fibrosis and basal subpleural honeycombing are predictive of worse pulmonary function and worse survival in patients with stage 4 pulmonary sarcoidosis. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Antimicrobial drug penetration is enhanced by lung tissue inflammation and injury. Rationale: pneumonia is a frequent and feared complication in intubated critically ill patients. Tissue concentrations of antimicrobial drugs need to be sufficiently high to treat the infection and also prevent development of bacterial resistance. It is uncertain whether pulmonary inflammation and injury affect antimicrobial drug penetration into lung tissue. Objectives: to determine and compare tissue and ball fluid concentrations of ceftaroline fosamil and linezolid in a model of unilateral acute lung injury in pigs and to evaluate whether dose adjustment is necessary to reach sufficient antimicrobial concentrations in injured lung tissue. Methods: after induction of unilateral acute lung injury, ceftaroline fosamil and linezolid were administered intravenously. Drug concentrations were measured in lung tissue through microdialysis and in blood and ball fluid samples during the following 8 hours. The primary endpoint was the tissue concentration area under the concentration curve in the first 8 hours, OX08H, of the two antimicrobial drugs. Measurements and main results: in 10 pigs, antimicrobial drug concentrations were higher in inflamed and injured lung tissue compared with those in uninflamed and uninjured lung tissue. Median ceftaroline fosamil OX08H, and interquartile range, equals 26.7 mgHL-1, 19.7 to 39.0, versus 16.0 mgHL-1, 13.6 to 19.9, p equals 0.02. Median linezolid OX08H 76.0 mgHL-1, 68.1 to 96.0, versus 54.6 mgHL-1, 42.7 to 60.9, p equals 0.01, resulting in a longer time above the minimal inhibitory concentration and in higher peak concentrations and dialysate/plasma ratios. Penetration into ball fluid was excellent for both antimicrobials, but without left-to-right differences. Ceftaroline fosamil, p equals 0.78, linezolid, p equals 1.00. Conclusions: tissue penetration of two commonly used antimicrobial drugs for pneumonia is enhanced by early lung tissue inflammation and injury, resulting in longer times above the minimal inhibitory concentration. Thus, lung tissue inflammation ameliorates antimicrobial drug penetration during the acute phase. Next, we will be discussing articles from Clinical Journal of American Society of Nephrology. Strategies to guide preemptive waitlisting and equity in wait time accrual by race/ethnicity. Background: use of ECFR to determine preemptive waitlisting eligibility may contribute to racial/ethnic disparities in access to waitlisting, which can only occur when the ECFR falls to less than or equal to 20 ml per minute per 1.73 meters 2. Use of an alternative risk-based strategy for waitlisting may reduce these inequities. For example, a kidney failure risk equation, KFRE, estimated 2-year risk of kidney failure, rather than the standard ECFR threshold for determining waitlist eligibility. Our objective was to model the amount of preemptive wait time that could be accrued by race and ethnicity, applying two different strategies to determine waitlist eligibility. Methods: using electronic health record data, linear mixed models were used to compare racial/ethnic differences in preemptive wait time that could be accrued using two strategies: estimating the time between an EEG for less than or equal to 20 at 5 ml per minute per 1.73 meters 2 versus time between a 25% 2-year predicted risk of kidney failure, using the KFRE, which incorporates age, sex, albuminuria, and EEG to provide kidney failure risk estimation, and EEG of 5 ml per minute per 1.73 meters 2. Results: among 1,290 adults with CKD stages 4 to 5, using the chronic kidney disease epidemiology collaboration equation yielded shorter preemptive wait time between an EFR of 20 and 5 ml per minute per 1.73 meters 2 in Black, minus 6.8 months, 95% confidence interval, C, minus 11.7 to minus 1.9, Hispanic, minus 10.2 months, minus 15.3 to minus 5.1, and Asian/Pacific Islander, minus 10.3 months, 95% C, minus 15.3 to minus 5.4, patients compared with non-Hispanic white patients. Use of a KFRE threshold to determine wait time yielded smaller differences by race and ethnicity than observed when using a single EFR threshold, with shorter times still noted for Black, minus 2.5 months, 95% C, minus 7.8 to 2.7, Hispanic, minus 4.8 months, 95% C, minus 10.3 to 0.6, and Asian/Pacific Islander, minus 5.4 months, minus 10.7 to minus 0.1, individuals compared with non-Hispanic white individuals, but findings only met statistical significance criteria in Asian/Pacific Islander individuals. When we compared potential wait time availability using a KFRE versus EFR threshold, use of the KFRE yielded more equity in wait time for Black, P equals 0.02, Hispanic, P equals 0.002, and Asian/Pacific Islander, P equals 0.002 patients. Conclusions: use of a risk-based strategy was associated with greater racial equity in wait time accrual compared with use of a standard single EFR threshold to determine eligibility for preemptive waitlisting. Association of EFR and albuminuria with venous thromboembolism. Background: CKD has been implicated as a risk factor of venous thromboembolism, but the evidence is limited to relatively healthy populations. The objective of this study was to discern whether parameters of kidney function and damage are associated with the occurrence of venous thromboembolism after hospitalization. Methods: we conducted a retrospective study including 23,899 and 11,552 adult individuals hospitalized within Geisinger Health System and New York University, NYU, Langone Health from 2004 to 2019 and 2012 to 2022, respectively. A Poisson model was used to evaluate adjusted incidence rates of venous thromboembolism according to EFR and albuminuria categories in each cohort. Cox proportional hazards models were used to analyze associations of EFR and urinary albumin to creatinine ratio, UACR, with venous thromboembolism, and hazard ratios, HRs, were meta-analyzed across cohorts. Results: both lower EFR and higher Walker were associated with higher risks of venous thromboembolism. In the Geisinger cohort, the incidence of venous thromboembolism after hospital discharge ranged from 10.7, 95% confidence interval, C, 9.2 to 12.6, events per 1,000 person-years in individuals in G1A1, EFR greater than 90 ml per minute per 1.73 meters 2 and Walker less than 30 mg/G, to 27.7, 95% C, 20.6 to 37.2, events per 1,000 person-years in individuals with G45A3, EFR less than 30 ml per minute per 1.73 meters 2 and Walker greater than 300 mg/G. A similar pattern was observed in the NYU cohort. Meta-analyses of the two cohorts showed that every 10 ml per minute per 1.73 meters 2 reduction in EFR below 60 ml per minute per 1.73 meters 2 was associated with a 6% higher risk of venous thromboembolism, HR 1.06, 95% C, 1.02 to 1.11, P equals 0.01, and each twofold higher walker was associated with a 5% higher risk of venous thromboembolism, HR 1.05, 95% C, 1.03 to 1.07, P less than 0.001. Conclusions. Both Efer and Walker were independently associated with higher risk of venous thromboembolism after hospitalization. The incidence rate was higher with greater severity of CKD. Next we will be discussing articles is from Kidney International Reports. Acute kidney injury duration and 20-year risks of CKD and cardiovascular disease. Introduction. Acute kidney injury, AKI, is associated with chronic kidney disease, CKD, and cardiovascular disease, CVD. However, it is unclear whether AKI duration affects the long-term risks of CKD and CVD. Therefore, we performed a population-based cohort study examining the associations between AKI duration and CKD and CVD. Methods. We identified patients with laboratory-recorded AKI in Denmark from 1990 through 2018. AKIs were categorized as rapid reversal AKI, less than or equal to 48 hours, persistent AKI, 2 to 7 days, and acute kidney disease, AKD, greater than 7 days. We estimated 20-year risks and adjusted hazard ratios, Rs, of incident CKD and CVD. Results. The study comprised 169,582 patients with AKI, with 100,478 and 76,838 included in the analysis of CKD and CVD, respectively. The 20-year risks of CKD were 26.3%, 29.5%, and 28.7% for rapid reversal AKI, persistent AKI, and AKD, respectively. Compared with rapid reversal AKI, Rs were 1.13, 95% confidence interval, C, 1.08 to 1.19, for persistent AKI and 1.36, 95% C, 1.30 to 1.41, for AKD. Risks and rates of overall CVD were similar for rapid reversal AKI, persistent AKI, and AKD. However, persistent AKI was associated with a slightly increased R of heart failure, 1.09, 95% C, 1.02 to 1.16, and Rs of heart failure, ischemic heart disease, and peripheral artery disease were slightly increased for AKD, 1.09, 95% C, 1.03 to 1.15, 1.11, 95% C, 1.03 to 1.19, and 1.10, 95% C, 1.02 to 1.17, respectively. Conclusion. AKI duration was associated with development of CKD, but not overall CVD. However, rates of heart failure, ischemic heart disease, and peripheral artery disease increased slightly with AKI duration. Systematic review of women leading and participating in nephrology randomized clinical trials. Introduction. Women are underrepresented in the leadership of and participation in randomized controlled trials, RCTs. We conducted a bibliometric review of nephrology RCTs to examine trial leadership by women and participation of women in nephrology RCTs. Methods. A bibliometric review of RCTs published in top medical, surgical, or nephrology journals was conducted using Medline and Embase from January 2011 to December 2021. Leadership by women as corresponding authors, women trial participation, and trial characteristics were examined with duplicate independent data extraction. Logistic regression was used to examine associations between trial characteristics and women leadership and trial participation. Results. A total of 1770 studies were screened and 395 RCTs met eligibility criteria. The number, percent, of women in corresponding, first, and last authorship positions were as follows: 89, 22%, 109, 28%, and 74, 19%, respectively, without change over time, p equals 0.94. The median percentage, interquartile range, IQR, of women trial participants was 39.0%, 13.5%, with no difference between women or men lead authors, p equals 0.15. Men lead authors were statistically less likely to enroll women in RCTs. Women lead authors were less likely to be funded by industry, odds ratio or 0.30, 95% confidence interval, c. 0.14 to 0.63, p equals 0.002, or lead international trials, or 0.11, 95% c. 0.01 to 0.83, p equals 0.03. Trials with sex-specific eligibility criteria were more likely to have women leaders, or 2.56, 95% c. 1.19 to 5.49, p equals 0.02, than those without. Discussion. Gender inequalities in RCT leadership and RCT participation exist in nephrology and did not improve over time. Strategies to improve inequalities need to be implemented and evaluated. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.